Read Mohammed.
Dr. Ashok, I think you can start your presentation now.
Hello, good evening. This is Ashok Parchani, uh, uh, assistant professor at Tau University of Hospital, Karachi. Today, I would like to talk about the diabetes mellitus and anesthesia. First of all, I want to hello.
Yes, we can hear you, Dr. Ashok.
Yes, I think there is some problem in slide share. Please wait for a while. Hello. This is a case scenario. A 20 years male rushed to the emergency operation room after sustaining traumatic brain injury for emergency craniotomy for the evacuation of subdural hematoma. He has no history of any comorbid. but presented in emergency room with altered sensorium with GCS of 6/15, high blood pressure, low blood pressure 90/50, and raised blood sugar 465 milligram per deciliter. I want to talk about the diabetes mellitus and anesthesia. The prevalence of the diabetes is increasing day by day, one of the most frequently encountered disease in anesthesia practice. It presents an emergency elective surgery related to their disease. 10% of patients admitted to the hospital have diabetes. Admitted patient in critical care unit with complications with pre and post operatively in ICU. We are facing growing diabetes crisis in our country. It is Pakistan is the third country in world with the highest diabetic adult population after China and India. Around 33 million people are diabetics, and same number is in pre-diabetic condition around the globe. 11 million adults have impaired glucose tolerance. Highest compared to diabetes prevalence rate is 30.8%. It caused 4 lakh deaths in country in 2021. More than quarter 26.9 of adults living with diabetes are undiagnosed. Diabetic medicines and insulin cost between 2 to 7,000 rupees in Pakistan. Some about the insulin, most important anabolic hormone secreted from the beta cells of islate of Langerhans and the pancreas. Normal secretion of approximately 50 units per day. Rate of secretion is determined by the plasma glucose concentration. It facilitates the glucose and potassium entry into the adipose tissue and muscle tissues. Role of insulin glucose transport is as a carrier protein, which facilitates the facilitated diffusion. The activation of the insulin receptors speed up the translocation of GLUT containing endosomes in the cell membrane. Facilitated diffusion of glucose into the cell increases about 10 folds in the presence of insulin. Lack of insulin leads to the catabolism and negative nitrogen balance. Around 1% of the pancreatic isolates in which the alpha and beta cells are present. The insulin is produced by the beta cells, and 99% of the organ contains the acinar cells, which secretes the digestive enzymes. Diabetes and insulin production depend upon the glucose concentration in the body, which stimulates the insulin in pancreas. And target cells little glucose from the blood, and blood glucose remains in the high. If insulin is absent, which leads to the increased concentration of high blood glucose. The target organ of the insulin is the liver, muscle, and fats. The effects of liver is it promotes the glycogenesis and glycolysis. It increases the synthesis of the triglycerides, cholesterol, and very low density lipoprotein 2 and proteins. It acts as the anti-catabolic hormone. It inhibits the glycogenolysis, ketogenesis, and gluconeogenesis. It is the same slide which shows that it acts on the liver, which leads to the glycogen synthesis and these things. The effects on the muscles is it increases the amino acid transport and protein synthesis. As an anti-catabolic hormone, it increases the glucose transport enhances the glycogenesis and inhibits the glycogenolysis. On fats, it promotes the triglyceride synthesis and storage, enhances the fatty acid absorption into the fat cells. It increases the glucose transport into the fat cells. It enables the intracellular lipolysis. The role of insulin in glucose transport: cellular membrane is permeable to glucose. It transported by carrier protein glucose or by facilitated diffusion. The activation of the insulin receptor speeds up the translocation of GLUT4 containing endosomes in the cell membrane and facilitates the diffusion of the glucose into the cell, increases 10-folds in the insulin. Diabetes mellitus is a group of metabolic diseases characterized by the hyperglycemia resulting from defects in the insulin secretion or insulin action or both. Diabetes mellitus is commonly called as a switch urine, group of metabolic disorders. Impairment of it causes impairment of the carbohydrate, protein, and fat metabolism. Due to the absolute or relative deficiency of the insulin, impaired insulin responsiveness or resistance, which leads to hyperglycemia and glycosuria. Diagnosis of the diabetes mellitus depends upon depends on the history, which most of the times glycosuria, increased urination, and some on the investigation. Symptoms of diabetes plus random blood glucose level is more than 200 milligram per deciliter, or elevated fasting plasma glucose greater than 126 milligram per deciliter, or glycosylated hemoglobin A1C is 6.5 or greater, or glucose tolerance test is more than 200 mg per deciliter. Classification: on the basis of classification, it is divided into mainly 3 types. Type 1, which is pancreatic beta cell destruction. Type 2, defective insulin secretion or insulin resistance. And third one is the gestational diabetes. A fourth one is sometimes included by the iatrogenic due to the some secondary type of disease, just in which most of the times a secondary disease is present, which leads to the diabetes mellitus, particularly iatrogenic steroid hormone and these type of things. Type 1 diabetes accounts for the around 5 to 10% of diabetic cases, which is characterized by autoimmune destruction of the pancreatic beta cells. HLA, TR3, and TR4 are more susceptible to develop diabetes type 1. Type 2 diabetes, it accounts for the 90 to 95% of cases, which is most of the times is insulin resistance and sometimes insulin deficiency. Gestational diabetes mellitus is 1 to 14%. It occurs most of the time third trimester, second at the end of the second trimester or third trimester. Secondary diabetes mellitus is associated with specific pathologies and other disorders. Type 1 diabetes is also called juvenile onset, juvenile diabetes. It comprises around the 10% of diabetic cases. It is due to the absolute insulin deficiency. Most of the times, it is immune-mediated destructions of insulin cells. Exogenous insulin is essential for cellular metabolism. Acute complications are more common. Type 2 diabetes onset in the childhood or adulthood. It comprises more than 90% of cases in adult population. It is secondary to, most of the times it is secondary to insulin resistance. Acute complications are less common. As figure
It's not.
shows.
Yeah, can you repeat it? Yes, your voice just vanished a minute ago.
Wait, I'm.
No, just repeat the slide, last slide,
Yes.
the last one.
Type 2 diabetes, it is onset in childhood or adulthood. It comprises more than 90% of cases. It is due to the insulin resistance and sometimes decreased insulin secretion. Acute complications are less common in type 2 diabetics. This picture shows the insulin whenever it is attached to the receptors which facilitates the glucose gestational diabetes, its onset in during most pregnancy may or may not persist postpartum. It occurs 1 to 14% of pregnant women. It reflects insulin resistance exacerbated by the effect of pregnancy. As picture shows the high glucose levels in mothers, which brings extra glucose to the baby and which may cause the macrosomia or increased weight of the baby. Pathophysiology of diabetes is still clouded. Multitude of factors may contribute, such as the environmental, immunological, endocrine, inflammatory, genetic factors are involved. The destruction, which leads to the destruction of pancreatic cells. Sorry. Pathophysiology of diabetes mellitus is its insulin deficiency, maybe insulin resistance, which leads to impaired carbohydrate, protein, and fat metabolism. Which leads to the disruption of micro and macrovasculature throughout the body, which ultimately leads to organ damage and dysfunction and failure. As this slide shows the most of the factors which leads to the type 2 diabetes mellitus, such as the obesity, impaired glucose tolerance, insulin resistance, ethnic background, sedentary lifestyle, family history, and age. These all factors are contributing to diabetes. The acute complication of diabetes mellitus, particularly type 1, is diabetic ketoacidosis, hyperosmolar ketotoxin, coma, and hypoglycemia. This is a very complicated slide. I have written basically we are going to discuss about the basic components of the diabetic ketoacidosis. Particularly, it is consists of the IV fluids, insulin, and potassium. A diabetic ketoacidotic patient presents with hypovolemia at around 4 to 6 liters deficit is there. Our management starts with the IV fluids, particularly the normal saline. We have to infuse, we have to provide hourly basis. And second component of the diabetic ketoacidosis management is the insulin, and third is the potassium. As patient is already hypovolemic, we have to provide, we have to infuse the normal saline and hydrate the patient and keep on the urine output and these things. Whenever and give the insulin 0.15 units per kg IV bolus or regular insulin, and 0.1 1 units per kg per per hour IV infusion. If glucose does not decrease by 5 to 70 milligram deciliter, then repeat IV bolus of the insulin or double the infusion of the rate. For the as potassium is concerned, if more than 5 milliequivalents per liter, no potassium is needed. If the potassium goes down and it is around 3.5 to 5, give 20 milliequivalents of potassium in each IV fluid. If less than 3.5, give 40 milliequivalents of the potassium in each drip. And check the glucose level hourly. If the potassium is more than 5 and serum glucose is not more than 300, it's not decreasing down, then we can go for the ketone body. Sorry, we have to repeat the electrolytes most with short period of time. If the potassium is within 3.5 and it is, then we can repeat electrolytes in 24 hours. It is this slide shows the difference between the diabetic ketoacidosis and HONC. In diabetic ketoacidosis, the most of the sodium remains between 125 and 135, and potassium remains normal or the high, and magnesium remains normal. Chloride, it is plasma ketones positive, +4, +3 in the diabetic ketoacidosis, and the serum bicarbonate level shows less than 15 milliequivalents per liter, and arterial pH 6.8, between the 6.8 and 7.3. As compared to HONC, there is more than 7.3 pH. And there is some other differences also very important, particularly sodium in HONC. There's sodium remains between the 135 and 45. Potassium, magnesium, chloride, these electrolytes remain in the normal. As far as osmolarity is concerned, in the diabetic ketoacidosis, there is osmolarity is between 300 and 320. In HONC, it increases from 330 to 380. As far as APG is concerned, in HONC, there is a pH around more than 7.3. So we differentiate between, and the decay is most, it occurs in the type 1 type of diabetes mellitus, which is initiated by due to some trauma, some infection, and these type of things. And the HONC or hyperosmotic ketoacidosis, which occurs most of the times in type 2 diabetics, and in which the glucose level remains more than 600 or more than 1200 milligram per deciliter. For the long-term complications, there are two types of particular complications: macrovascular and microvascular. And as far as an anesthetist we are concerned, the stiff joint syndrome is very important for we people. For macrovascular complication, which leads to the hypertension, coronary artery disease, peripheral vascular disease, and CVA, cerebral vascular disease. As microvascular complications occur most of the times, it usually develops within 15 to 20 years, and it depends upon the diabetic control of the patient. In these type of things, most of that are the nephropathies, neuropathy, autonomic neuropathy, and peripheral neuropathies. In autonomic neuropathy, patient develops hypertension, painless myocardial ischemia, orthostatic hypotension, lack of heart rate variability, reduced heart response to atropine and propranolol, arresting tachycardia, early satiety, neurogenic bladder, lack of sweating, and impotency. The anesthetic implication of the neuropathy are these patients are most of them have silent ischemia, pulmonary aspiration, hemodynamic instability. Specific operative problems in diabetics is stress response of surgery with catabolic hormone secretion, prolonged interruption of the food, and the hold hold of the insulin may leads to the hyperglycemia, hypoglycemia. And these type of patients may lead to the diabetic ketoacidosis, and if we are not properly managing in these type of the patients, may leads to the catastrophe. The impact of stress response to surgery on diabetics, it may lead to the catabolic state, and the relative deficiency of insulin and increased resistance may lead to the hyperglycemia and increased mortality, particularly type 1 diabetics. Most of post-operative complications leads in most of the patients they present with increased wound complication and delayed the discharge of the patients. The anesthetic consideration are divided into the three subgroups, such as the preoperative, intraoperative, and postoperative periods. In perioperative, our concern is to maintain the optimal glycemic control, evaluation for the end organ damage, and optimization. Sorry. The perioperative risk stratification is very important in these type of patients because of these patients may have silent ischemia and have silent MI, and we have to we have to do workup on cardiovascular, renal and stiff joint, autonomic neuropathy and aspiration risk, and acute diabetic emergencies. So we have to take complete history and examination, and the particularly investigations are important regarding the cardiovascular system, renal function, due to they may lead to the morbidity and mortality. Preoperative investigations are very important, particularly complete blood count, which may show the TLC count increase, and it can tell about it can update about the infection and these type of things. Urine analysis is very important. There are 25 to 30% of the patients diabetics present with microalbuminuria, and may leads to the kidney disease. Urea, creatinine, electrolytes, random blood sugar, fasting blood sugar, HbA1c. It tells about the glycemic control of the patient, and X-ray chest and ECG, and particular echo is very echo. ECG may show the poor progression of R wave, which may be due to the previous MI and these type of things. But the most of the times patient doesn't know the status of his heart and these things. So the X-ray chest, ECG, and echo are very important, particularly in long-standing diabetics. As far as the monitoring is concerned, basic standard monitoring is implied, particularly pulse oximetry, ECG, non-invasive blood pressure, and tidal, and case analysis is necessary. Optional is invasive monitoring is important, and particularly the end organ damage, such as the renal failure, cardiac failure, and complicated surgery or other things in which most too much hemodynamic instability or volume is concerned. during intraoperative period, we have to most keep an eye or most we have to take care of the infection, because these patients are more prone to infection and these type of things, and they may lead to the hemodynamic instability, aspiration of gastric acids, and difficult intubation, hypo and hyperglycemia. We have to take care, and we have to more focus on these type of things. So these things may lead to the diabetic decay and hypoglycemia type of things. Intraoperative management. Hello. Hello.
Yes, please carry on, Dr. Ashok. We can hear you.
Thank you. For intraoperative management is concerned, we should put on the morning list, and keep particularly sterilization should be proper, and slow titration of the anesthetic agents are very important. These patients are, as we already told you, that these patients have abnormal response to these drugs, and these patients we use to titrate the anesthetic agent slowly and gradually, and frequent blood pressure monitoring, and we prepare the vasoactive agents. In intraoperative management, the position of the patient is very crucial. We need to take care of the patient position, and ideally we should before anesthetizing the patient, we should take the information about the how much movement is there, particularly the joints and the neck movement. We should take history, and then we should take care of the particular position of the patient. All preparation for the difficult airway management should be ready, and aspiration prophylaxis ideally should be given. And sometimes most of the even 40 to 50% may have early satiety and gastric aspiration type of things. So we should may consider them in for rapid sequence induction. Particularly if possible, we should prefer the regional technique. Regional technique is better, particularly attenuation of the stress response to surgery and modulation of catabolic hormones. Less requirement of insulin is required. Early oral intake, reduced nausea and vomiting, and easy glycemic management. The early recognition of hypoglycemia can be is very important in this type of. Particularly if the patient is awake, we can recognize early in these patients. In intraoperative period, we take care of the hypoglycemia and hyperglycemia. If the glucose level is more than 12 millimoles, in which we need to titrate the insulin, and we should send ketone bodies. We should assess the ketone bodies for the DKA. If these are normal, then we should rule out the other causes of the hyperglycemia. Maintenance of optimal glycemic control is very important. Strict or loose control of glycemia is important. In these type of patients, we most of the time we keep keep sugars 140 to 180 milligram per deciliter. The consequences of hyperglycemia, which leads to hyperosmolarity, dehydration, acidemia, fatigue, weight loss, muscle wasting, infection, poor wound healing, increased mortality, worsens the neurological outcome, and myocardial ischemia. We have two strategies for insulin infusion. One is the boluses on sliding scale or continuous infusion. The bolus regime of the insulin-dependent diabetic patient is very important. Maintain the intravenous line. Check morning blood glucose. If blood glucose is at least 150 milligram per deciliter, administer half of the morning dose in form of the intermediate acting insulin. Start 5% dextrose water, 1.5 ml per kg per hour. If 10% is 5%, 10% dextrose water is available, it is around 1 ml per kg per hour we should administer. Administer supplemental dextrose if the patient is hypoglycemic, particularly glycemia is around less than 4 millimoles and 4 millimoles. In these patients, stop the insulin and give the supplemental dextrose water. Intraoperative hyperglycemia more than 150 and 180 is treated with intravenous regular insulin according to the sliding scale. For continuous infusion, add regular insulin to normal line in concentration of 1 unit per ml. Start infusion 0.1 unit per kg per hour. The dose may be approximated units per hour is equal to plasma glucose divided by 150. In somewhere it is written that in catabolic state, 150 is replaced with 100. A general target of blood glucose in this situation is 180 milligram per deciliter. Add 20 millicoulombs to each liter of blood. Problems during insulin therapy is the absorption of insulin on the surfaces of syringes, IV fluids, pegs. And most of the in different hospitals, it is ruled that the insulin should be discarded after 24 hours. So it is very important to take care of the insulin and these type of things. And we have to manage the hyperglycemia. The management of non-insulin dependent diabetes mellitus, stop the oral hypoglycemic drugs, particularly the sulfonylureas and metformin, around 24 hours. It is started after post-operatively when the patient resumes the oral intake. And for metformin is concerned, it is recommended that the 48 hours should be awaited and then we should start. It is contraindicated in particularly lactic acidosis and renal failure of the patient, in renal failure patients. Patients undergoing for major and prolonged surgeries require insulin treatment intra and post-operatively. In insulin-dependent diabetes mellitus, we have to monitor 1 hourly. In non-insulin dependent diabetes, we have to monitor 2 to 3 hours. For post-operative management, close monitoring of blood glucose, insulin on sliding scale are infusion and pain management. For the pain management, it is very important. Multimodal analgesia is recommended, and I think it is sufficient for today. Thank you. Any question, Dr. Asman?
Dr. Ashok, thank you so very much for giving an insight on the basic, but as this is this forum is for the updated or the recent guidelines. So do you have any recent guidelines to, for our participants to know?
Yes, it is now, they are now variable insulin infusion they are recommending. Most of the times we are using the same scale as for glucose divided, plasma glucose divided by 150 ml per hour. And recently they are recommending the variable IV insulin infusion, and it is recommended that there is the 4 to 7 milliosmoles, the 1 unit per hour is transfused, and it is 1 Sorry. And in which the 1 millimole of 1 unit is hourly. If the 7 to 9 millimoles, it is recommended the 2 units of insulin are given. New recommendations are still regarding the oral hypoglycemic. Some drugs are omitted and these type of things. Any particular question you want to ask? Hello.
Yes, any questions from the participants, please? Okay, so Dr. Ashok, can you please summarize the new guidelines for these diabetic patients who are being anesthetized? And I have one question in the chat box. Awesha has asked, after anesthetizing the diabetic patient, what measures we should focus upon? So can you kindly, yes, can you kindly first answer Awesha's question and then my question, please?
Yes, we are. We start from the pre-operatively. No? Most of the times we reduce the, if we are preparing for the patient who is diabetic, and we put on the list on the first on the list. If a patient is taking the insulin once in evening dose, we reduce the 20% of night dose. If he is taking once daily in morning and once and evening, we reduce the day before the surgery and on the day of the surgery, 20% of the insulin dose. If someone is taking twice, one injection twice, biphasic or ultra long acting, we have the usual morning dose. In a person who is taking 3 to 5 injections, basal bolus regime, omit the morning dose and lunchtime dose. A short-acting insulin we should start. In developing countries, we are most of the times using the technique in some regime, GKI regime, and these type of things. And as far as oral hypoglycemic drugs are related, in acarbose, maglitide, we omit the morning dose, and new guidelines, it is recommended that the metformin may take as normal. But in previous days, we were think most of the time they were hold for 24 hours and even not started after the 40, even then started after the 48 hours of the things. And for the pioglitazone and these type of drugs, they take as normal. There is no need to stop the oral hypoglycemic drugs, such as the sitagliptin and sexagliptin. We should continue the same dose, and there is no need to stop the these drugs. These are new recommendations, as I know.
Yes, and Dr. Ashok Awais has asked that after anesthetizing a diabetic patient, what are the measures which should be taken and which we should focus upon?
We should monitor the blood glucose hourly. As I have already told you, that we should measure the blood glucose level in the hourly in insulin dependent diabetics, and we should continue the insulin glucose infusion in these patients. If we are not doing this may lead to the diabetic ketoacidosis and these type of things. We have to particularly monitor for the glucose control. We have to maintain the 140 to 180 milligram per deciliter. Start and take care of the movement and these type of things, as long as we have to basically monitor these things. Hello. Yes, ma'am.
So there is another question by Mamuna Sheikh that type of surgery matters, minor or major. And there was another question that can you please elaborate on the dosing of opioids with respect. Okay, so we'll come to Yunusa Yusuf Ali's question after Mamuna Sheikh's question. And she was also asking about dexamethasone giving routinely should be avoided in diabetics.
There are two school of thoughts. Yes, if indicated is steroid is indicated, we have to give in steroids. Yes, we can manage the glucose level by increasing the insulin dose. Of course, if in particularly the neurosurgery and these things, we can't hold the glucocorticoids or dexamethasone. In these conditions, we have to manage the blood glucose level by managing the insulin infusion and these types of things. Second question, Resma.
Type of surgery, does type of surgery matters, minor versus major in, I think, Mamuna, can you please ask directly that what does your question, can you please elaborate your question? You are you asking that minor versus major surgery? Are you asking about the diabetic control, or are you asking if the patients are uncontrolled diabetics, which type of surgery is indicated? We actually cannot understand what you have just asked. So can you please unmute yourself and ask the question? Regarding monitoring blood glucose levels.
Yes, it is recommended if the we have to maintain the glucose level 140 and 180 milligram per deciliter. Previously, it was the recommended the tight control, but many studies have been done which doesn't show the any difference between the outcome. So we have to manage the blood glucose level 180 milligram, 140 to 180 milligram per deciliter. So we need to manage the insulin level. If it is not, it is more than 12 millimoles per liter, it is recommended the ketone bodies should be done to manage. There are a lot of chances of become diabetic ketoacidosis. So we have to manage the blood glucose level. No doubt, glucose level, electrolytes, and uh, uh, hydration. So we have to particularly keep an eye in uncontrolled diabetics. It is recommended the glucose level should be done hourly, and insulin, glucose, insulin, dextrosaline should be continued till the patient has resumed the oral intake.
Dr. Ashok, can I add on, please?
Yes, of course, of course.
So as far as your question is concerned, Memuna, if I'm understanding it correctly, so there are recent guidelines. Actually, these are not the guidelines, but the guidance from the Royal College of Physicians of which was published back in, I think, 2022, which is like quite recent. And they have mentioned that there are certain kind of care which should be given to the patient, but those plans should be individualized for each and every patient. And the surgical plan should also be considered before taking the diabetic patients in. The factors which should be addressed should be the type of diabetes the patient is having, the glucose anti-hypoglycemics the patient is having, the HbA1c level which that person or the patient is recently have, along with the urgency of the procedure also matters. And if there is any kind of metabolic derangement which is present at the time of presentation, whether it be an emergency case or an elective case, it also deters the route of the patient to be taken care of. And along with that, the level of NPO, which is nil per oral status of the patient, or the missed meal status of the patient, that also matters. So once the patient is taken into the theater, like if the patient has been taken and let it be an emergency case or an elective case, So the fasting period should be minimum of, it should be taken care of, should be a minimum of 6 hours. And one should continuously monitor the blood glucose levels, which intraoperatively should not be less than 108 approximately, which is in between 6 to 12 millimoles, which is approximately 108 milligrams per deciliter, to a maximum of, as Dr. Ashok has just mentioned, 140 or 150, approximately 150 milligrams per deciliter. But there is again a debate on loose hypoglycemic, loose glycemic control versus the tight glycemic control. But whatever the patient is having right now, one should have a clear consistency and demarcation on, and these diabetic coverage should be given to all the the nurses and the doctors after the patient has been shifted from the theater into the ward, with the control of sugars and the endocrinology on board. This is what I last read, but I'm not, I haven't read it recently. So I think this was the latest from those guidelines.
Yes,
If I'm not
yes,
wrong, Dr. Ashok.
yes, Asma, you are very right. These things are recommended that the minimum should be NPO period. It is around, should be 6 hours. And it is recommended that the patient, whenever it is admitted, the blood sugar should be done, and the HbA1c should be done. If the
Right. And I think HbA1c, which was mentioned, was around 8.5, which needed to be
yes,
corrected
yes.
afterwards. But before, I think 8.5, it was not recommended to, correct it tightly, as far as I remember. But you might be knowing it correctly, if I'm not wrong.
Yes, there is a variation. Some literature says that should be 8, below 8 for the elective surgeries. If it is a some literature says that if the 10 there is a the elective surgery should be postponed, and some it is somewhere written, if the blood glucose level is 400 milligram per deciliter, one reading or two readings are 400 milligram per deciliter, the elective surgery should be postponed and wait should awaited to maintain the glycemic control.
Right. So in continuation with the similar question, Rahman Jan has also asked that in cardiac surgery, what should be the target glucose levels? And because in, I think, good diabetic control duration HbA1c levels for the elective surgery, I think he's asking about the even it is usually high in many non-diabetic patients during cardiac procedures as well. So we will come to Yunusa's question after that. But before that, would you like to have your answer on this, Dr. Ashok, please?
Yes, of course. Basically, if the as literature says, and these are evidence-based, that we should keep on the if the better control is there, there will be less chances of problems, or less chances of morbidity and mortality. It is better to be discussed with the diabetic team. Basically, it is a multidisciplinary approach. It is there should be a surgeon, anesthetist, and the diabetic team should be on the same board, on the same page. And it is recommended that ideally there should be HbA1c between 4 to 7. 7 is recommended, but it's depend upon the urgency and condition of the patient whether we can wait, or we have to go for the semi-urgent type of surgery. It's depend upon the person's on the patient and the type and the procedure.
So you are saying that HbA1c of more than 6.5 or 7 should be treated with continuous insulin infusions, and whether those be cardiac patients or not, the treatment regime remains the same.
Yes. Previously, it was recommended that the no insulin, no glucose type of these things were we have learned in previously. But now it is recommended the type 1 should not be go without the insulin and glucose or the dextrose water. It is recommended that we should give insulin to prevent from the diabetic ketoacidosis, particularly in the type 1 type of diabetes. And a new recommendation is that now we should keep eye on the type 2 diabetes, and we should give or we should provide the insulin and glucose to prevent to reduce the chances of the electrolyte imbalance and these type of hypovolemia and these type of things.
Hypovolemia or hypoglycemia?
Sorry, hyperglycemia.
Yes. So now coming back to our last question, which is by Yunusa Yusuf Ali. Can you please elaborate on the dosing of opioids with respect to learn or ideal body weight? If the surgery is only amenable to general anesthesia, what are the opioids of choice? So Yunusa, can you please unmute yourself to clarify your question? Because to my understanding, this is a generalized question on opioid given to general anesthetic patients, or do you want to clarify it in some other context that is not clear from your question? So can you please elaborate on that? Is Yunusa here? I hope she's here. Yes, Yunusa, can you please, Yunusa Yusuf Ali, can you please unmute yourself to please clarify your question, clearly question? Okay, so we are not clear what she exactly wanted to ask. And now let me check and go through the chat box. So Jennifer Rose has asked, what is the target glucose level for uncontrolled type 2 diabetes, diabetic patients for the elective surgery?
In uncontrolled and type 2 diabetics in uncontrolled situation, we are give lose control. These type of, it is recommended, it is around, it should be less than 200, but it between the 200 and 180 milligram per deciliter. In these type of patients, it is recommended that the loose control should be followed.
Yeah, yes, Mamuna, do you want to ask another question? You have raised your hand.
Yes, I just wanted to ask that we always talk about silent MIs in diabetic patients, but is there any strategy or some tips to detect and monitor for silent MIs, especially intraoperative period and post-op period? Because patients are usually tachycardic and hyperglycemia blunts, multiple responses, autonomic neuropathies. So how do we detect or have a high index of suspicion for silent MIs?
These patients are real. Yes, of course, they are more prone to silent MI. But in intraoperative period, patient will there will be some changes, particularly the hemodynamic changes, which will show. These patients, we are monitoring the 5-lead ECG monitoring. It will some changes. The patient will, of course, will tell you the hemodynamics, that the hemodynamics of the patient will tell you the changes. In these type of situation, we will suspect and we go for the 12-lead ECG. There's no way to, there's only one way to prevent these type of complication is to maintain the hemodynamics and maintain the heart rate and maintain the tube volemia. Yes, of course, if in complicated surgery, there are chances of even it is literature shows there are more. These are non-ST elevation type of the MI are may occur within 48 hours. Yes, we can manage it with proper pain management, hemodynamics, and proper recommended glucose control level in these type of patients.
Just to add on to Dr. Ashok's answer, usually, Mamuna, what we monitor in the operation theater is the ECG lead, which is set on lead 2. But lead 2 does not indicates the rest of the cardiac arrhythmias, or it indicates arrhythmias but not ischemia. So for
Yes,
ischemia
the problem.
detection, usually CM5 lead is used, in which the position of the lead is changed from, I think, from other leads to, it is made to be placed on I think intercostal level 5 or something. So that's why it's called cardiac monitor 5 lead, and that is one of the indicators of the patient having ischemia. But if it is indicated with the ST depression, or any other changes which occurs intraoperatively to such patients, so lead CM5 can indicate, but in such patients, then 12 lead ECG would be rather better monitor afterwards. After the surgery has been done, then 12 lead ECG can be done, and intraoperative, because otherwise troponins can also be can be a misguidance because of the surgical stress and the surgical technique. So at times they might not be too indicative, but yes, CM5 can indicate intraoperatively if any cardiac event is happening.
Yes, Asama, you are very right. But CM5 and most of the time the hemodynamics of the patient. If intraoperative we have the TE, we can monitor, or we can know that wall abnormality may be seen before the changes in the ECG. It is recommended that the 12 lead ECG should be done during intraoperatively if you feel that there is something going on, there are some changes, or there is some problem during the intraoperative. I want to share one case scenario, and particularly I have seen a patient in a tertiary care hospital which presented with pulmonary edema, some sort of pulmonary edema. The surgeon was suspecting that the anesthetist is given the patient overloaded with the fluid, but a cardiologist has seen that patient, patient, and even there was no ECG changes. We were so amazed that there is no ECG changes, and the patient went into the pulmonary edema intraoperatively. Then we go for the quantitative trop I. There shows that there will be become some event which leads to the pulmonary edema and hemodynamic instability. It is very important. No doubt we have to monitor the CM5 hemodynamics changes, and then we can follow that the quantitative
yes, so luckily we have Dr. Akbar Mistry with us, who is also the cardiothoracic anesthetist. So Dr. Akbar, thank you for joining us, but would you like to have a comment on this question?
I think the best possible way in order to assess ischemia is obviously transesophageal echo, but unfortunately it's not available at many of the centers, even internationally. But besides that, CM5 configuration and 5 lead ECG is also good enough. Obviously, you won't be able to actually visualize wall motion abnormality, but it can give you a rough idea of inferior wall MI or lateral wall MI most of the time. I've seen a couple of times such things have happened in our OR, especially those patients who had been admitted with non-ST elevation MI, and right before going to the pump, they developed another episode of myocardial infarction, and we picked that up using the ECG only. So in the cardiac ORs, we often tend to use 5 lead ECG, and that helps us with monitoring of ischemia as well as arrhythmias.
Thank you so very much, Dr. Akbar. I think there are no more questions to that. So I would request everyone to kindly fill in the feedback form to get their e-certificates. Thank you so much, Dr. Ashok, for your presentation.
Thank you.
And I really hope to see all rest of the people in our next lecture, which is by Dr. Faisal Khan on 16th of January. So thank you, everybody,
you.
for joining us, and kindly fill in the feedback forms.
Thank you, Dr. Asma.